Today we are going to cover Chapter 19, which encompasses the male genital and reproductive systems. Throughout this talk, we're going to discuss many of the different types of pathologies that we see in the male reproductive system, but first let's start with some general anatomy. So the testes and the epididymis are responsible to pass sperm to the vas deferens. The seminal vesicles are involved in secreting many of the different components that comprise semen. In males, we also have a prostate gland. So what's running through the prostate, what's running through the center of the prostate gland is actually the urethra. And this extends from the bladder to the penis, which basically allows urine to flow out of the body. And the prostate itself secretes fluid that nourishes and protects sperm. And all the structures that you see on this slide are susceptible to inflammatory disorders, different types of neoplasms, as well as structural defects, which we'll discuss in a little bit. In terms of cancer in males, well, prostate cancer is actually the most common cancer in males in the United States of America. And BPH is one of the most common disorders of the aging male population. If you don't take anything else away from this lecture, please make sure that you know about BPH, as the boards love the test benign prostatic hyperplasia. So an enlarged prostate gland can cause a lot of different pathologies to happen. It can cause uncomfortable urinary symptoms by blocking the flow out of urine, by blocking the flow of urine out of the bladder, for instance. And it can also cause urinary tract and other kidney manifestations, which we'll discuss in this talk as well. And as males age, the reproductive system undergoes general atrophy. So the testes become smaller, the seminiferous tubules actually thicken, and by this thickening, this allows or impedes on sperm production, essentially. So the thickening of the tubules impedes on sperm production. The prostate gland will enlarge. Just how large will it go? The prostate gland itself is usually about the size of a walnut in a non-hyperplastic prostate, so about 20 grams. In BPH, it can enlarge 10 times that size and actually be about 200 grams. So the prostate does have a big capability to enlarge. There could also be sclerotic changes and disrupting local blood flow. And the sclerotic changes can also lead to sexual dysfunction as well. Androgen deficiency, a lot of men will suffer androgen deficiency. This can include problems with the testes, the hypothalamus, and the pituitary gland. And then the arteriosclerosis. So if any male has any type of peripheral vascular disease, this peripheral vascular disease also has the capability to affect the vessels that are supplying the testes and the penis. So arteriosclerosis is something to be aware of. Now we're going to move into discussing some of the disorders of the prostate. And as you can imagine, the term prostatitis means inflammation of the prostate. But prostatitis itself actually refers to multiple disorders that can cause pelvic pain and discomfort, ranging from the conditions that are listed on the slide here, acute bacterial prostatitis, all the way to complex conditions that have very complex pathologies. So let's start by talking about acute bacterial prostatitis. This is actually the most common type and the easiest one to treat. And in the clinic, most men are going to come in and they're going to have this oscillation of feeling very cold and feeling very hot. So chills and fever. They're going to kind of, when one goes up, the other one's going to go down. They're going to present with this waxing and waning of chills and fever. And also they will display hypotension, so low blood pressure. The patient may also complain of pain that radiates to the lower back and genital area. Another manifestation that may be seen with disorders of the prostate includes urinary complications. So urinary frequency and urgency, or burning or painful urination, may all be complaints that the patient may say. And just general body aches. So the body aches don't have to necessarily be in the lower back and genital area. They could be anywhere in the body. And then as we move into chronic pelvic pain syndrome, this is actually classified into 3 subcategories: inflammatory, non-inflammatory, and asymptomatic inflammatory. So when it's inflammatory, there's a presence of white blood cells in the urine, usually on urinalysis. In the non-inflammatory condition, as you can imagine, there's no white blood cells in the urine. And then the asymptomatic inflammatory, there are going to be presence of white blood cells in the urine. However, the patient may not complain of any of the symptoms that I listed, the chills, the fever, the hypotension, things like that. Most likely the patient's not going to complain of hypotension. That's something that you're actually going to notice on physical exam. So they will complain of the chills and the fever, but not necessarily the hypotension unless they say they feel a little weak or something like that. So again, both inflammatory and asymptomatic inflammatory classifications of chronic pelvic pain syndrome will have white blood cells in the urine, but the inflammatory is the one that's going to present with the symptomology. And then the non-inflammatory chronic pelvic pain syndrome, there's not going to be any presence of white blood cells upon urinalysis. One really important thing to note about all the different types of prostatitis is that it's going to predominantly manifest in men who are younger than the age of 40. Some of the things to also ask your patient about or to look for on the medical charts is, for instance, if they have any type of recent history of catheterization, if they have a history of sexually transmitted infections, and if they're still currently active. And if they are, it's very important to ask them if they've been having sex with multiple partners and whether it's been hetero or homosexual sex. Another very important thing to differentiate because of the susceptibility to getting various types of STIs. If the man is younger than 40 years of age, the #1 cause of prostatitis in young men is going to be infection due to chlamydia trachomatis. If chlamydia is not the main culprit and is caused by some other pathogen, it's most likely going to be E. coli. However, E. coli is not going to be a pathogen that's going to be transmitted sexually a lot of the times. So if you have a young man who's engaging in risky sexual behavior and is complaining of the symptomology associated with prostatitis, I would think chlamydia trachomatis. Look out for that question on your board exams. If the male is not sexually active, then I would think of the different types of gram-negative pathogens that it could be, such as E. coli, Proteus, Klebsiella, as well as Pseudomonas aeruginosa. Another factor that could play a role in the pathogenesis of the different types of prostatitis is autoimmunity. And autoimmunity itself may play a role in chronic prostatitis because up to a third of men with prostatitis have elevated levels of specific molecules that regulate the inflammatory response. And there's also another hypothesis about autoimmunity and the fact that many of the men affected by the different types of prostatitis actually have overactive pelvic floor muscle trigger points. And because they have these overactive trigger points, the muscles are working. At times they shouldn't be working and potentially inducing an inflammatory response. Again, just a hypothesis of the autoimmunity associated with the different types of prostatitis. And what you actually see in this cytological slide is a gram-negative stain of chlamydia trachomatis. And encompassing prostatitis, as we mentioned, comes that oscillation of the fever and chill episodes. So at one time the patient's going to be hot, then it's going to be cold, and then he's going to be hot, then it's going to be cold again. So look out for this oscillation of fevers and chills. Also look out for a history of urinary tract infections, different types of STIs the patient may have encountered in his life, and if the patient just complains of general pelvic discomfort. So it's really important for you all as physicians to be able to differentiate between the different types of prostatitis and benign prostate hyperplasia and cancer of the prostate. So this PSA, this prostate-specific antigen, it's actually elevated in both benign prostatic hyperplasia and in cancer associated with the prostate. But we'll talk about that in a few slides. But prostatitis itself is usually differentiated from BPH and prostate cancer by the presence of pain and age. So more than half of men with prostatitis are going to be younger than the age of 45, whereas BPH and patients who are suffering from prostate cancer are going to be older than the age of 45. Very important for you to note. And again, we need to do a urinalysis to diagnose this, and this is going to be done by the primary care physician a lot of the time. And in order to see if there's any type of abnormality with the prostate, the primary care physician or the urologist, depending on who's doing the test, is going to do what's known as a DRE, a digital rectal exam. So they're going to place a finger in the rectum and feel the prostate and look for the texture, see if they can detect any nodularities, any toughness or excessive softness, things like that. And what you're looking at in this diagnostic image is actually a unilateral unenhanced CT, which is depicted on the left, and a enhanced CT, which is depicted on the right. This is a CT scan of a 48-year-old male who complained of perineal pain. And the arrows are actually indicating a periurethral abscess and displacement of periurethral calcifications from the midline. So again, this is a type of prostatitis. So this is causing inflammation of the prostate due to this particular abscess and this calcification that's there. A lot of times, the acute episodes and even the chronic episodes of prostatitis can be resolved through a treatment of antibiotics. And there's actually optional treatment for the different types of chronic pelvic pain syndrome. So remember the three subtypes we talked about: the inflammatory, non-inflammatory, and the asymptomatic inflammatory. So with the treatment for that, it's relatively unknown because how complex the pathology is. And actually the cause of non-bacterial prostatitis is unknown. Treatment is often given to people to provide symptom control and just generalized relief. So now looking at the prostate itself. The prostate is obviously a muscular part of the male reproductive system. It's shaped like a walnut, weighs about 20 grams, and actually consists of 5 different lobes that surround the urethra. And remember, the prostate is responsible for producing seminal fluid that nourishes and transports semen. So what you can see here is actually a hypertrophic prostate. And remember, we said the prostate that's not hypertrophic would be about 20 grams. A hypertrophic prostate can weigh up to 200 grams. So it can 10 times its size. So BPH itself is an age-related, non-malignant enlargement of the prostate gland. And it's defined as having a prostate volume, or PV, greater than 30 milliliters. The disease is very, very rare in men under 40 and tends to become symptomatic after the age of 50. And it's actually called hyperplasia because the pathologic changes are marked by hyperplasia, not hypertrophy. So remember, hyperplasia is an increase in the number of cells, not hypertrophy, an increase in the size of cells. And the nodules develop, which you can see in the picture here, and these are developing as a result from the proliferation of epithelial cells, smooth muscle cells, and stromal fibroblasts of the prostate gland itself. And DHT, so DHT is metabolized from testosterone. It's the biologically active metabolite of testosterone, and it's thought to be the primary mediator of hyperplasia, whereas estrogens have the capability to sensitize the prostatic tissue to the growth-producing effects of DHT. So a lot of times BPH is treated with 5-alpha reductase inhibitors, such as finasteride. So these 5-alpha reductase inhibitors are going to actually stop the conversion of testosterone to dihydrotestosterone. Just one of the treatment methods for BPH. Also, saw palmetto is a treatment that's a natural 5-alpha reductase inhibitor. And as you can imagine, look at the bottom picture, the shape of the urethra in a normal prostate. Remember, the urethra is running right through the prostate. And then if the prostate starts to enlarge, it can actually compress the urethra and narrow the lumen of the urethra. BPH can also result in hormonal imbalances, and as we mentioned, the different types of nodules due to the increased number of cells. The clinical presentation of BPH is related to secondary involvement of the urethra. If the prostate grows too large, well then urine flow can become restricted. LUTS, L-U-T-S, stands for lower urinary tract symptoms. And the LUTS can occur in two different forms, the first being storage and the second being voiding. And storage includes issues that the patient may complain of, such as nocturia, frequency, and urgency, while voiding includes hesitance, intermittency, or a weakened stream. You may also see with BPH an overactive bladder, so this is usually associated with uninhibited detrusor contractions. And as the urethral obstruction progresses, the risk of actually developing urinary tract infections, as well as bladder distension and destructive bladder wall changes, actually increases. Two other conditions that could be elicited are known as hydroureter and hydronephrosis. So a hydroureter refers to a dilation of the ureter, actually refers to the ureter wall as it becomes severely stretched secondary to the bladder outflow obstruction, which increases the pressure in a retrograde fashion. And then we have hydronephrosis. So hydronephrosis refers to the distension of the renal calyces and pelvis with urine as a result of obstruction of the outflow of urine distal to the renal pelvis. And if the prostate gets too enlarged and the urethra becomes completely obstructive, it can actually lead to end-stage renal disease, coma, and death. And as I mentioned earlier, saw palmetto is a natural treatment, yet not approved by the FDA to treat BPH. And again, it's a 5-alpha reductase inhibitor. And what that does is that inhibits the conversion of testosterone to dihydrotestosterone. The next thing mentioned is lycopene. Lycopene is a carotenoid, which is a natural pigment that gives some vegetables and fruits their red color. It's also an antioxidant, so again, it helps our cells to protect themselves from oxidative damage. And it's really interesting with tomatoes. Tomatoes actually produce about 80% of the lycopene that's found in the U.S. diet. So again, with medical management, the primary care physician or the urologist is going to do a digital rectal exam and do different types of urodynamic tests. One of the urodynamic tests looking at normal flow pattern is depicted on the slide here. So as you can imagine, when you are voiding urine yourself, you reach a maximum stream, and then again the stream starts to trickle off eventually. So the physician is going to look at the voided volume, the maximum flow rate, the average flow rate, and also the time to maximum flow, and look at different criterion using different norm values and referencing to determine if there's any type of issue with micturition. And then some other diagnostic tests that might be ordered would be diagnostic ultrasound as well as MRI. Oh, and I also want you to note that the uroflowmetry is a screening modality and it's not a diagnostic tool. You're going to come in contact with all age ranges of patients in the clinic, so it's very important for you to know about the elderly population. I can imagine that some of us know people who are suffering from urinary complications now, if not directly related to us, good friends or family friends. These questions here are some really good questions that you could ask your patients if you suspect any type of prostatitis or BPH or some type of chronic pelvic pain syndrome. Ask them, do they urinate more than every 2 hours or more than once during the night? Do they have trouble voiding? Do they have trouble starting or continuing the stream? Is it interrupted? Is the stream weaker than it's previously been? And does it feel like you're not able to empty completely? However, a lot of these diagnostic tests are going to be done by medical doctors, so as PTs. It's really important to know the symptomology, be able to get the patient the proper referral, but also to not overwork the patient with different types of exercise. If the patient's suffering from prostatitis, it's very important to modify your prescription accordingly and treat the symptomology and provide general comfort in order to prevent end-stage renal disease from happening. reiterating the fact that it's very important for you all as physical therapists to be able to differentiate between the different types of prostatitis, benign prostatic hyperplasia and prostate cancer. On this slide, I want to focus on prostate cancer. So the most common type of cancer of the prostate is the adenocarcinoma of the prostate. And as you can see here depicted, the lesions aren't raised. It doesn't look, in my opinion, as gross as benign prostatic hyperplasia. So remember, with BPH, we had all those nodular lesions due to the increase in number of cells. But you can also think that those lesions are raised off the surface of the prostate, and you can kind of look at it and think of where you could take a scalpel and kind of cut away those lesions, and they probably don't go very, very deep in the prostate itself. However, if you're looking at adenocarcinoma, well, the lesions, you can see them depicted by the yellow circular areas and irregular circular areas. That looks very deep to me. It doesn't go superficial, so that would make me think that there's more tissue involvement in adenocarcinoma of the prostate compared to BPH, which also would make me think that this might be a very more severe condition. And prostate cancer is actually pretty frightening, as 1 in 6 men will sometime develop prostate cancer in their life. And although a genetic marker has not been found, a significant increase in risk has been estimated for men who have both first and second degree relatives with the disease. So we don't really know if there is a genetic component, but there are correlative studies that show if you have it in your family, you're more susceptible to getting it yourself. Excuse me. Also, you may develop prostate cancer if you have any type of exposure to cadmium. Those who may have been exposed to cadmium include welders, anybody in the alkaline battery production, and a lot of times farmers. Farmers who are using heavy steel, doing welding, they're also predisposed to developing prostate cancer. And is there an endocrine system link? Well, as you know, everything in pathology talks to one another, essentially. So androgens have been implicated. And the endocrine link itself has to do with dysregulation of the hypothalamic pituitary tract. There's lots of different studies on there. I encourage you all to do your own research and your own investigation if you're interested in looking at the dysfunction and dysregulation of the hypothalamic pituitary tract and the development of adenocarcinoma. Lots of literature on it. Very interesting stuff. And what you're going to see on histology is these disorganized, moderate-sized glands present throughout the prostate section. There's going to be an infiltrate of the prostate stroma, and systemically in the patient may present with elevated levels of insulin growth factor and different types of antigens. One of the therapies, or even a prophylactic therapy for prostate cancer, is testosterone injections, as testosterone promotes cell differentiation. And one of the theories about giving testosterone injections is that this promotion of cell differentiation to a malignant cell could actually protect against the development of prostate cancer itself. And a very interesting research finding I came across is that there's some research that suggests osteonectin actually has the capability to attract prostate cancer cells to bone, and once they are attracted to the bone, osteonectin has the capability to stimulate the cells to invade the bone, and they go through that seed and soiling phenomenon that I talked about that we also see in the chordoma cancer. And adenocarcinoma itself, it can be asymptomatic for a very long time, and usually it's noted incidentally on digital rectal exams. So the patient may be asymptomatic. That's why it's encouraged for patients older than 45 to do routine prostate health checks. And as I mentioned, the prostate adenocarcinoma can be asymptomatic. It's very difficult to diagnose without the proper diagnostic imaging because there are a variety of pain complaints. Pain can range from a dull, vague ache that may be located in the rectal, sacral, or lumbar spine region, or it may be a very sharp pain that's radiating to the back. And again, you're looking for symptomology in order to refer to the patient to get the proper treatment by the MD, and hopefully the MD will get the proper diagnostic imaging test ordered, and hopefully the radiologist can find what is actually going on. In addition to the varied pain complaints, the patient may also experience obstructive symptoms, and obstructive symptoms include urinary urgency, frequency, hesitancy. The patient may complain of painful urination, dysuria. They may have blood in the urine, hematuria, and also may complain of difficulty initiating or continuing the urine stream, and just a general decreased urine stream and voiding volume as well. This cancer also, so we talked about the role that osteonectin plays. This cancer also has the capability, once it's metastasized to the bone, to go to the liver and the lungs via the lymphatic system. Interesting with adenocarcinoma of the prostate is there's actually some evidence saying that this cancer may be preventable with a non-toxic oral agent such as vitamin E, selenium, or soy. However, those studies are very limited. Take them for what you will. The prostate-specific antigen test is actually a blood test that measures the enzymatic protein manufactured only in the prostate gland. So it's a very specific and sensitive test. And upon DRE, a physician may notice a hardened or fixed structure or a diffusely undulated gland. Again, that's all going to be done by the primary care physician. So going back to the PSA, so PSA should be between 0 and 4 nanograms per milliliter, and PSA itself is not diagnostic because it can range from 4 to 10 depending on different conditions. PSA itself can actually be elevated in multiple conditions, so it's not exclusive to adenocarcinoma of the prostate. It can be elevated in BPH and prostatitis, as we mentioned, and even as a normal aspect of aging with no symptomatic pathology associated with it. So if you expect this, if the physician comes and finds this hardened, fixed structure, usually they're going to order an MRI, which is seen in the diagnostic image on the bottom right-hand corner of the screen. And the MRI actually allows for evaluation of the prostate gland and the regional lymph nodes to see if there's any type of lymphatic spread. The staging is based on an A through D scale. Don't worry too much about the staging. If the prostate cancer itself has not metastasized, if we can see on MRI that it's usually confined to the prostate, a lot of the times a prostatectomy would be ordered along with appropriate radiation, chemo, and other types of cancer treatments in order to attempt to eradicate the carcinoma, or sorry, the neoplasm. Now we're going to move out of talking about the prostate and discuss some of the disorders of the testes. So the first is orchitis, and orchitis is an inflammation of the testes, which can be acute or chronic, and most of the times it's associated with epididymitis, so that could result in testicular pain and swelling, and also unilateral scrotal pain that may radiate to the groin. We'll talk about epididymitis in a little bit. Anyone with primary infections of the genital urinary tract is at risk for developing orchitis. And the bloodstream and lymphatics are the main routes of spread from other body organs to the testes themselves. Again, we talked about the age ranges. So if somebody's older than 45, expect BPH, the adenocarcinomas of the prostate, where if they're under 45, expect the different types of prostatitis. And a lot of the times we're going to talk about the differences between prostatitis and whether or not testicular torsion is present. So you're looking for some type of insidious onset. So an insidious onset will often be suggestive of infection, whereas a sudden onset can raise the question of testicular torsion, which we're going to talk about. So testicular torsion is usually going to be induced by some type of accident, and it is it's a medical emergency, so the patient needs to be rushed to the ER and surgery needs to be performed immediately. So with epididymitis, you really have to look for the patient's history. So if the patient has been engaging in any type of risky sexual behavior with multiple sexual partners, then you can think that there might be some type of involvement of the bacterial pathogen Chlamydia trachomatis. Also differentiating whether this is some type of prostatitis or some type of BPH or cancer, it's really important to look at the patient's age again. So other than bacterial causes of epididymitis, it can also be caused iatrogenically, and the iatrogenic sources include cytoscopy as well as indwelling catheters. A lot of the times what the patient is going to complain of is unilateral scrotal pain, but the patient may also complain of pain in the lower abdominal region, in the flank, the groin, or in the hip adductor muscle area. And usually elevating the scrotum will relieve the pain, especially elevating the scrotum side that the patient's complaining pain is on, if it is unilateral. And usually on complete blood cell count, there's going to be an elevated white blood cell count present with epididymitis. And for the acute phase of treatment, you just want to encourage the patient to rest, limit their physical activities, do scrotal elevation and generalized supports. It's okay to tell them to give ice packs and put ice packs on the affected area. You can also do a sitz bath, NSAIDs, or antibiotics. So epididymitis and testicular torsion are two completely different entities. Epididymitis is not a medical emergency, while testicular torsion is a medical emergency. So testicular torsion is an abnormal twisting of the spermatic cord as the testes are rotating within the tunica vaginalis. The tunica vaginalis is the pouch of serous membrane that covers the testes. Testicular torsion is usually induced by some type of blunt trauma. So you're usually going to see this in young male athletes, but please note that it could be congenital as well. So if there's any type of congenital abnormality, such as absence of the scrotal ligaments, any type of incomplete descent of the testes, or maybe a high attachment of the tunica vaginalis, these could all be congenital abnormalities that result in testicular torsion that also need to be fixed immediately. What you can do as a PT to assess testicular torsion, if you haven't already seen that the patient's in excruciating pain, is you can do a diagnostic test known as a cremasteric reflex. So by stroking using some type of item that you use for two-point discrimination, or even like the end of a Q-tip, with the cremasteric reflex, this should induce retraction of the scrotum and the testes as the skin on the same side of the inner thigh is lightly stroked. The absence of the scrotal retraction is a positive cremasteric sign, and absence of the cremasteric reflex. And if the patient has an absent cremasteric reflex, it's almost always because there's some type of nerve compression that's occurring when the testicle is twisting on its spermatic cord. Another really important thing when assessing the testicular region is the room temperature of the room which you're treating your patient in. Very important. What happens if the examination room is cold? Basically, when you're cold in males, the body sends a message to the scrotum to shrivel and preserve heat. So you may even get a more absent cremasteric reflex, even if the patient does not have testicular torsion if the room is cold. So something to be aware of. A lot of the times, the patient, in addition to their excruciating testicular pain they're going to be experiencing, they may display nausea, vomiting, tachycardia, and lightheadedness. And the more severe the pain, the more extra symptomology the patient is going to display. And the surgery needs to be performed pretty rapidly. If the surgery is performed within the first 3 hours of initial testicular torsion, then there's actually an 80% salvage rate. But after those 3 hours, your rates go down nearly exponentially. Testicular cancers can be classified as seminomas or non-seminomas. These are both germ cell tumors that originate from the primordial germ cells, and they make up more than 95% of testicular tumors, while the remaining neoplasms are mostly tumors of the stroma or sex cord origin. Testicular cancer, as most cancer that we've come across in pathology, has an unclear etiology. Potentially there may be a hormonal imbalance. Testicular cancer could develop from a condition known as cryptocortism, and this is usually found very early in life. Cryptocortism occurs when the testes don't descend into the scrotum. And depicted here are all the different areas where testicular cancer can develop if the cryptocortism is not fixed. There may be congenital components. There is a specific mutation of TGCT1 on the long arm of chromosome X. And men with Klinefelter syndrome, so XXY males, so 47 chromosomes with the extra X chromosome, they're actually at a greater risk of developing testicular cancer compared to a 46XY male. The seminomas appear as a solid gray white growth, and they are rarely necrotic or cystic. So you can see the seminoma in the top picture there. Non-seminomas include embryocarcinoma, teratomas, choriocarcinomas, or yolk sac tumors. Luckily, seminomas are very sensitive to radiation therapy. Non-seminomas, they're actually more common than seminomas, but they also tend to grow more quickly. And they're often made up of more than one type of cell, and they're actually identified according to their cell differentiation. And then we have yolk sac tumors in infants. These are actually the most common giant cell tumors that are found in infants. And these tumors will result in enlarged testes, which appear grossly as poorly defined lobulated masses. And a lot of the times you'll see focal areas of hemorrhage with the yolk sac tumors. So the seminomas, the non-seminomas, and the yolk sac tumors will all present clinically almost identical. So it's very important to look at the age. Look for the yolk sac in very young, and the non-seminomas and seminodes in the older population. So as I mentioned, they're going to present clinically very similar. You're going to see the enlargement of the testes. Diffuse pain could be local and referred. The cancer has the capability to spread lymphatically, and the mass itself may cause testicular swelling or hardness or some combination of these findings. And these findings could be accompanied by an ache in the abdomen or scrotum or a general sensation of heaviness. It's really important to note that metastatic testicular cancer, so again, there's obvious lymph node involvement, it's spreading lymphatically, and if it's metastasized, it can present as back pain as the primary complaint. So back pain should be a red flag for you. There's no known preventive strategy, but promoting testicular self-exam is recommended. And there also may be some of the tumor markers elevated that we've seen earlier. So the elevation of alpha-fetoprotein that we saw in other pathologies, the elevation of human chorionic gonadotropin hormone, or HCG, and also the elevation of lactate dehydrogenase. So the staging and grading is based on the TNM system and staging 1, 2, and 3. So in stage 1, what's happening is the tumor is actually confined to the testes or the epididymis or the spermatic cord, and no metastases are present. In stage 2, it's metastatically spread to the retroperitoneal lymph nodes, and then it's divided into another subclassification of A, B, and C according to the size of the lymph nodes. And in stage 3, there's a distant metastases or high serum tumor marker values. Cisplatin chemo is the way to go. It can actually cure very advanced disease. It's actually shown to cure diseases that have metastatic spread are in stage 3. So cisplatin is one of the awesome chemotherapeutic drugs out there. A lot of the times the surgeons will do organ-sparing surgery. This has become actually an accepted approach to treat malignant and non-malignant tumors of a single testes. And the chemotherapy itself, especially the cisplatin chemo, is used in all stages of the seminoma and non-seminoma, as I mentioned earlier. So there's actually clinical evidence showing that it's cured stage 3 seminoma and non-seminoma before, which is pretty cool. With early detection, there's more than a 95% cure rate for the testicular cancers, which is awesome news. So now we're going to move away from testicular cancer and talk about penile cancer. With penile cancer, the median age of onset is 68 years of age. It's a very rare malignancy and has a decent 5-year survival rate, about 50%. There's a condition I want you to pay attention to known as phimosis. Phimosis is a congenital narrowing of the opening of the foreskin so that it cannot be retracted. A lot of time you see phimosis in people who are not circumcised. So the phimosis can, if the urethra is narrow, there can be all these different harbors for pathogens, different types of bacteria, viruses, fungal, etc. And phimosis has been linked to the development of penile cancer. Lots of different types of penile cancer: squamous cell, papillary, basaloid, warty, varicosus, and sarcomatoid. Basaloid and sarcomatoid actually carry the worst prognosis. Penile cancer is going to look very painful. You're going to see a lot of lesions. The patient will complain of pain. There may be excessive bleeding from the lesions and a very unique foul odor with penile cancer a lot of the times. The most common locations for penile cancer include the glans penis and the prepuce. These regions account for more than 50% of all penile cancer. So it's very important to get screened for phimosis. If you have not been circumcised, it's very important for good daily hygiene in order to prevent any type of reservoir for bacteria or fungal or viruses to harbor. And there's actually a cream, a superficial 5-fluorouracil cream that can be put on different types of lesions that has shown to have pretty good effectiveness. There's also laser therapy, surgery, and local incisions that can be done. Erectile dysfunction is defined as the inability to achieve, keep, or sustain an erection for satisfactory sexual performance for both partners, and may include a problem with libido, penile erection, ejaculation, or orgasm. Erectile dysfunction will ultimately lead to impotence. And ED actually affects 152 million men worldwide. Listed on the slide here are different risk factors for developing ED. The underlying etiology is relatively unknown. However, it can be associated with a neurogenic, arteriogenic, venogenic, psychogenic, or pharmacologic effect. So in 70% of men younger than 35, the cause is psychogenic, actually. With the neurogenic, we talked about the different brain area, how the pons relays the signal down the spinal cord, has the capability to innervate the visceral and the splanchnic nerves, and that signal eventually gets into the bladder, signals the detrusor muscle, and allows us to void, and it also allows for sympathetic and parasympathetic activation, inhibition, and regulation, balance of sympathetic and parasympathetic innervation to allow men to achieve erections and then to go back into a flaccid state. So there's a big neurogenic component, which we're going to talk more about in neuroscience class, but please be aware that ED carries a big psychogenic component, but also has a very big pathophysiology component, and it could be a side effect of different pharmacologic drugs. A lot of times in depressed patients, they're prescribed SSRIs. One of the main side effects of SSRIs in men is the inability to achieve an erection. So you treat one thing, you cause another symptom. pick and choose your battles. So there's actually a necessary coordinated interaction between the regulatory centers in the diencephalon, the brainstem, and the spinal cord that is needed to have proper sexual function. And if any of this area is disrupted, if there's any break in the chain of the connection or the signal, this could cause some of the neurogenic components of ED. Again, the mechanisms are unclear, but please pay attention to the fact that there's a big physiological and psychological component of stress that's elicited by ED. Could cause a lot of tension between partners. Imagine, making yourself feel like you're a failure, or having somebody tell you you're a failure. Can be very devastating mentally and really inhibit your quality of life. So signs of ED could include the need for more physical stimulation to induce an erection, less firm erections, longer time to reach an orgasm, a decreased force of ejaculation, an increased time needed to get an erection after orgasm, fewer spontaneous erections, and erections that are lost during sexual intercourse. So these are all symptoms that could signal that maybe you're suffering from ED. Lots of men clinics around. ED is very highly treatable. So one of the main treatments for ED on the market was actually designed as a cardiovascular drug, but the inventors discovered that it did something else in terms of vasodilation elsewhere. The phosphodiesterase 5 inhibitor, Viagra, sildenafil, and this is a multi-billion-dollar drug. The guy who invented this. Sildenafil is a lifesaver to men suffering from erectile dysfunction. Men can also go to testosterone clinics around. There's several of them that opened up recently in Tampa, and get testosterone injections. Testosterone injections, what they do is they relax the arterioles and smooth muscle of the corpus cavernosum, and they increase the cavernous arterial blood flow, hence causing an erection. But, there's just something to think about, just some common sense physiology. As we age, we become more sedentary, less active, right? Think about when men are younger. It's usually the boys that have a lot of sexual desire, and then sexual desire tends to fade as men age. So think about the general day of a boy. A boy is very active, regular exercise, maintaining a high metabolic state. So one of the causes could be of ED could be just a sedentary lifestyle. So it's very important for you all to encourage your patients to do regular exercise, keep their cholesterol low, eat a healthy diet, just kind of live their life in terms of the metabolic state and the health state geared towards a younger man. Obviously, not do any of the recreational drugs that you may have done as a younger man or anything like that, but definitely make sure that you're exercising and keeping that high metabolic state. That could really help out with the ED a lot. So exercise itself, as you may know, prevents coronary artery disease and diabetes. So it's just good for you. Just do it. Just move. And I just wanted to review some of the questions about the case study with y'all. So let's go over this question. Which of the following individuals is most likely to have post-surgical complications after a bariatric procedure? So the correct answer is actually B. So after a bariatric procedure, think of all the stuff that's involved, okay? So a history of a DVT, a deep vein thrombosis. If a thrombosis breaks off, then it becomes an emboli, right? Every patient in here has a big body mass index, right? Way above the obese classification. But with the DVT, anytime there's surgery and the changing of blood flow, using things to suppress heart rate and things to elevate heart rate, DVT is a big complication. I think something you should definitely be aware of. Also the obstructive sleep apnea. So breathing, every surgery has an anesthesiologist there. The anesthesiologist monitors the sedation rates as well as the respiratory rates. So two big complications. Where if you look at choice A, osteoarthritis, yeah, these patients all probably have osteoarthritis in some fashion, but that's not really going to be a post-surgical complication. In choice C, GERD, yeah, I guess choice C would be the second best answer, but GERD is going to be something that's has relatively unimpactful symptoms. So we've all experienced GERD in some fashion, gastroesophageal reflux disease. We've all ate something spicy or kind of burped up the contents of something. GERD wouldn't really have much to do with post-surgical complications. And then again, whether it's a 42-year-old female or a 55-year-old female with knee osteoarthritis, that's kind of outside the scope of this question here. And the last question, a physical therapist is walking in the hall with a patient who had Roux-en-Y gastric bypass surgery 3 days ago. The patient suddenly complains of abdominal cramps, pain, and lightheadedness. These findings are most likely indicative of, and the correct answer is C, dumping syndrome. Dumping syndrome is actually caused by consuming refined sugar or energy-dense foods, and is initially experienced by 75% of people with Roux-en-Y gastric bypass surgery. And signs and symptoms include abdominal cramping, pain, tachycardia, nausea, tremor, flushing, lightheadedness, syncope, and diarrhea. So a lot of the times, patients after the Roux-en-Y gastric bypass surgery, they're going to be on a liquid diet, but it's very important to watch what liquid they're consuming because sometimes they will like to have sugary stuff, and patients can actually drink too much fruit juice that may cause dumping syndrome to occur. Choice A, orthostatic hypotension. This usually occurs with postural changes and doesn't typically present with abdominal pain. The incisional hernias, they're very uncommon immediately after surgery and are usually later manifesting pathology. So with incisional hernias, you usually have to do something that elicits some type of force to induce the hernia. And then again, while knee osteoarthritis is very common in obese individuals, you saw it in 2 answer choices in the previous question, the symptoms of osteoarthritis would be knee pain and general stiffness. So again, choice C is the best answer.